Welcome to PharmaDocs with your host, myself, Dr. Jay Resnick, and Dr. John Robertson. Practicing oral surgeons bring you the latest and greatest in pharmacology as it affects you in your daily dental practice. Well, good afternoon, John.
Hello, Jay. Good afternoon. How are you?
Good.
Everything good out there on the West Coast?
Yeah. We've actually had a little cooling in the weather, which is nice. It hasn't been quite as hot. It hasn't been over 100.
Please, I don't want to hear about that. Okay, we're just begging for rain over here, brother. Begging for rain. All right.
Yeah, we got a little, but I just can't believe it's September 15th already.
September 15th, but I tell you one thing you can believe in and take it to the bank, Jay, all the time. The approval of new drugs is always going to happen. In fact, tonight's show, we've got 10 new drugs to talk about. 10. All right.
Wow.
And that's the second largest. That's the second largest this year. The other time we had 17 and we culled some of those out.
Yeah.
Just for their applicability toward dentistry.
Right.
But always going to be new drugs. Got to know what to do, how to treat them and so forth.
Exactly. So you're going to have patients on them. You're going to have family members on these drugs, and you've got to know what impact this will have on your practice of dentistry. If you need to modify anything, things you need to look out for, and that kind of thing. So why don't we get right into our slides?
Let's do it.
Go. And so here we are, September 15th, PharmaDocs, and we are first going to thank our sponsors, iCore RX, which is part of iCore Connect. They are an e-prescription system that will work with just about any device, whether it's your phone, whether it's your laptop, your computer at the office, your tablet. And if you're not already prescribing prescriptions electronically, definitely check them out.
Right.
Our newest sponsor is Fortune Law Firm, and they are a group that doesn't represent you if something happens as far as malpractice is concerned, but their interest is in protecting your assets, but also giving you tax strategies and estate planning so that you can maximize your retirement and minimize the taxes you have to pay. And we happen to have joining us from, actually, I'm not even sure where he is, Joshua Johnson, who is with the Fortune Law Firm. And he's going to tell us just briefly a little bit about what Fortune does for its clients.
Welcome, Josh.
Thanks, John and Jay. I really appreciate it. And
absolutely.
Yeah, it's been great working with you guys. So real quick, what the Fortune Law Firm is, we are a law firm out of Las Vegas, but we operate nationwide. And kind of our little claim to fame, or our little phrase is that we actually used to sue doctors, so now we protect them. And sometimes it takes the best offensive coordinator to be the best defensive coordinator because you understand all the plays. In those times. In those years of suing doctors, Zach never lost. Mm-hmm. There wasn't ever a time where he lost that lawsuit, and we want to know why. What are the things that made the big difference? There were a whole lot of doctors and a whole lot of people that thought, I got the right strategy, I got the right team, I got the right structure, I'm set, right? But that wasn't the case when the day actually came. So what we do is we want to go through with a fine-tooth comb and make sure that your structures are correct, that your patient paperwork, your employee paperwork, that the entities that you have are actually executed correctly, because oftentimes we see doctors are really good at being dentists and doctors, but sometimes these business things get forgotten, like did you do your meetings and your minutes? I know a lot of us are guilty of not keeping up on our meetings and our minutes and those corporate formalities that allow us the protections of those entities. For sure. So we want to take a look at that. We take a look at the way that your personal life is structured also, because lawsuits can come from anywhere. It doesn't have to be malpractice. It could be general liability. It could be a lawsuit from your personal life, from an underage kid driving your car. It doesn't always have to be malpractice. So we want to take a look at if you have any rental properties or if you have any personal assets, how are those structured so that we have a whole protection of not only your practice, but your personal life and your assets as well. When it comes to malpractice, when it comes to your license and your practice, when you have a lawsuit and your malpractice pays out, your name and your license are reported to a federal agency called the National Practitioners Database, the NPDB. From there, it goes to state boards. State boards can investigate. Your insurance rates go up. If you have hospital privileges, you have to do the disclosure every time you do your peer review. You have to self-report to the DEA. If you don't self-report, you can lose your prescription writing abilities. But the most important one is that state board. If the state board comes out and investigates, they don't always just investigate the incident or the lawsuit or whatever happened. They investigate every single thing in your practice. Everything is on the table for them to inspect. And we see doctors get suspended, lose their license, fined for nitpicky things completely unrelated to the original lawsuit. Like we had a doctor lose his license for 6 months for subpar chart notes, meaning he used too many acronyms in his chart note, in a chart that they found. So the idea is to keep them out of the practice, keep them at bay by never having your name show up on the NPDB. So when the NPDB was set up in the 80s, there was a corporate shield that they set up, kind of a loophole for big hospitals. But we help you navigate those corporate protections for hospitals, group practices, and clinics, so that your name never gets put on the NPDB, even if you have a payout. So you're none of that cascade of events ever happens for you. So we protect your license. Then we do an estate planning. We do want you to have a living trust. Most all of us know that we need one, but a lot of us don't, or if we do, they're outdated. It's not asset protection because there's different types of trusts, and I won't get into that, but it is a holistic, we want to cover everything, and we want to protect your estate from going to probate at that time. Then the last thing we do is those advanced tax strategies. Most of our CPAs and our people doing our taxes, our accountants, are looking for deductions, and that's kind of their only strategy that they have is let's find more deductions, and they don't actually strategize and look for everything that you could possibly be doing. One of our favorites is the research and development tax credit, the R&D tax credit, meaning, and that research and development has been around for 30 years, but it used to be you have to research and develop something new to the universe. But in 2017, it became a permanent part of the tax code where it just has to be new to your practice. You have to innovate something. And dentists and dental specialties we're finding are the best candidates for the research and development because you're always improving your practice. You're always improving the way that you practice dentistry. So we're averaging about $30,000 per year for our clients, and we can go back 3 years. So if we find you $30,000 of a tax credit, which is a dollar for a dollar tax credit, it's not a deduction.
Wow.
We could go back 3 years. So maybe we might find you $60,000, $50,000, $90,000 in actual dollars tax credits that you're going to use to pay your tax liability.
There's so many CPAs don't know about all these different strategies to save on taxes that are completely legal and legitimate. Like you said, they just want to focus on deductions because they don't really even CPAs that their clients are a lot of physicians and dentists. Still, they're not very innovative.
The reason is, how can your CPA write a 300-page report on cone beams that's going to get upheld by the IRS? They don't even know what a cone beam is, let alone be able to write a 300-page report on how the way that you've innovated and the unique way that you're doing that, or you're doing aligners or these things. That's out of their realm. They can't do that. So our attorney, who's also a dentist, he's a dentist and an attorney, writes our research and development tax credits, and they're awesome. We love them.
Josh, let me ask you a question. So, I've been lecturing on medical emergencies for over 20 years, and Jay and I just did a webinar a couple of weeks ago as well too, and it was very interesting to hear the comments from many of the dentists that had no idea they could be sued beyond their malpractice limits, because many people were responding back saying, well, that's why I have malpractice. But if you have a catastrophic outcome in your office and you are sued beyond your policy limits, and if possible, you're found grossly negligent. And of course, that's going to be different in every single state, but all of your personal belongings could also be on the chopping block as well, too. And I just see that if I was a dentist and I had a medical emergency program in place, and I had Fortune Law Firm as my asset protection firm, and I had a bad outcome, do I call my malpractice carrier first, or do I call you guys first?
For malpractice, I'd still probably recommend you call your malpractice, but definitely make us the second call, because we want to help you navigate, like I talked about, the corporate shield.
Yes.
For your license, and also to make sure that it's done correctly. Oftentimes, the malpractice attorneys, they're unfamiliar with the process. They don't know that these laws exist. We have to kind of educate them, show them the laws on how we can actually protect you, protect your license, protect your name. And yes, if you have a lawsuit and it goes over that malpractice, or you have a general liability, or you have a slip and fall, that's not malpractice. You have a vicarious liability for one of your employees that's operating outside of the practice. That can easily go over the limits of your insurance. Zach and his buddies, when they were, suing doctors, they broke records. They broke the records for the largest settlements, and the largest settlements over the insurance limitation.
Yeah, sounds great to have you guys on the dentist side. Yeah. So if someone wants to find out more information about Fortune Law, I guess we can go back to that slide. The fortunelawfirm.com is the website. And to get a hold of Josh, what's the best way to get a hold of you?
Yeah, you can schedule a personal consultation. We'd love to just sit down with you, look at what you're doing, look what can we do better. And we don't charge that. We'd love to have a free personal consultation with everybody. You can go to thefortunelawfirm.com/consult. Okay.
Sounds easy enough. All right. Well, great. Josh, I want to thank you for joining us this evening. We really appreciate your Fortune Law being a sponsor of this webcast, and we really appreciate you taking time out of your schedule to give our viewers a little insight as to exactly what Fortune Law Firm does.
Appreciate it. Thank you.
Thank you, Josh, so much, and thank you, Fortune Law Firm.
All right, so now let's get on with the shoe. All right, so there have been a few things in the news of note, and so we'll just talk about those really briefly. And one of them has to do with the fact that in addition to fentanyl, there are new opioids that are hitting the streets that are many times more dangerous and many more times more likely to result in fatality than fentanyl, because these drugs are getting mixed in with the fentanyl. And
the IMFs
buying it, the opioid addicted people who are using fentanyl don't know that these fillers are added in order to basically for the distributors or whoever manufactures gets these drugs out on the market can make more money. And that's really what it comes down to.
And Jay, these drugs are the nitazines, and of course, xylazine is the main one right there. And so, when you and I were talking the other night on that webinar, you brought up the fact that if you suspect some type of overdose and you've given them naloxone, and remember, we want to spread that out over a 2-minute period. And if you give them another dose and they're just not waking up, you need to start thinking about, is there another source here?
Yeah.
But more importantly, maintain that airway.
Yep.
All right.
Keep them breathing. Keep that airway open. Yeah. The nitazines are like 1,000 times more potent milligram per milligram than fentanyl. Really crazy. And xylazine is on the radar. Gotten many alerts from the DEA. The other, it's known on the street as Trang. And it's a veterinary anesthetic medication.
Yes.
It's an analog of clonidine, so it's not an opioid, but you add that to an opioid like fentanyl, and you've got nothing but trouble.
Well, and that's the reason why we're still seeing more overdose deaths as well, too. But the next point, Jay, look at that. U.S. heart deaths have linked to obesity have tripled in 20 years. Tripled.
Yeah.
Okay. Yeah, so,
triple.
I mean, again, we talk about this, Jay, and this is for all of our listeners. A patient red flag is obesity. Okay. Yeah. When they walk in your door and they have a BMI greater than 30, that's a patient red flag sitting right there in your chair.
Yeah. Okay? And 42% of Americans are now considered to be obese.
And that's up 10% from a decade ago. Yeah. 42%. We're almost halfway there, Jay.
Yeah. It's gotten to be a major problem. And, death is usually from, arteriovascular disease, or to heart disease itself.
Well, in the white fat itself, you build up all these inflammatory chemicals that increases your clotting risk, as well as a buildup of more coronary plaque.
Yeah.
Okay.
Yeah.
So when that person's sitting in your chair and they're obese, all right, it's just a ticking time bomb. Period.
Yeah. People just are not as active as they used to be, and they are basically eating fast food for many of their meals and not cooking healthy foods or eating healthy things. And they lay around and watch TV all night. And that's contributing to it. And of course, it's geographically, it varies from area to area, but overall 42% of Americans, and the number is not going down.
No.
And speaking of heart deaths, cardiac arrest.
Sudden cardiac arrest. Actually.
Sudden cardiac arrest.
That's right.
We always thought, patients just kind of drop dead. They go into VFib, and unless you're there right away to defibrillate them and maintain CPR, there's not much you can do. But some studies have come out showing that 50% of people who had a sudden cardiac arrest experienced at least one telltale symptom the day before, which was most commonly chest pain in men and shortness of breath in women.
And guess what? I mean, that's something we should be asking people every single day of their medical history already. You know?
Hey, and patients that have high blood pressure, diabetes, underlying heart disease, they're the ones that are more likely to have an acute MI and cardiac acute cardiac arrest, and need and basically go into VFib.
And Jay, we talked about that last time on our webinar. I told you about that about a year and a half segment where I lectured a lot for the Goldman Dental Management Company, and over 1,000 dentists I showed a video to did not know the answer to the medical emergency in that video.
Yeah.
And that, of course, I'm giving away the answer. So if anyone attends one of my lectures, you're going to know, but it was sudden cardiac arrest. Okay.
Yeah.
And the length of the video was 4 minutes. And more companies are now start saying we need to be a 4-minute city. What does that mean? We got to be able to defibrillate you in 4 minutes or less to save your life.
Yeah.
And then Jay, one other thing that made the news, I didn't get it to you in time. It talked about the inappropriate antibiotics prescribed by dentists led to like $30 million in wasted prescriptions. Yeah. Okay. Dentists are the top prescriber for clindamycin. All right. And of all those antibiotics prescribed last year, all right, so 167 million people went to the dentist. 5%, or roughly around 8 million people, got antibiotics. They're saying 80% of those got inappropriate antibiotics.
Yeah. And clindamycin's been associated just recently with higher rate of implant failure and delayed bone healing.
Yes.
And then there are all kinds of problems if you prescribe. So if you have a healthy patient and you're doing, let's say, instead of 4 full bony impacted wisdom teeth, I never give them antibiotics. Okay? Simple extractions, never antibiotics. If we're going to do a graft, I put them on like 5 days of antibiotics. They start the day before and go for 4 more days afterwards. And that's it. And I may even kind of change my habits with that, because, like I said, these studies are showing that antibiotics given along at the same time as implant placement or bone graft procedures have a higher failure rate. But
and Jay, get ready for this. Of all those patients prescribed the clindamycin medication, 768 developed C. diff.
Yeah.
768. So those were in hospital patients. Okay.
Yeah.
So an antibiotic prescribed by a dentist led to a patient having to be admitted for C. diff.
Yeah.
And Jay, get ready for this.
Yeah.
103 cases of anaphylaxis.
Yeah. Yeah.
And
that's one of the risks of giving multiple exposures to an antibiotic to a patient, is
Right.
they can one day, just out of the blue, now have an anaphylactic reaction to that medicine you've given them many times. So you want to try to limit the number of times you give it to them. In addition, what happens is that, especially if you give them a short course of antibiotics, like 2 or 3 days, something like that, what you're doing is you're basically killing the susceptible bacteria and allowing the less susceptible bacteria to flourish, that are going to be resistant to clindamycin or amoxicillin or whatever you're giving them. And in fact, if they still develop an infection, even though you put them on antibiotics, it's going to be much harder to treat, because these you've selected out bacteria, pathogens that are already resistant to penicillins, clindamycin, et cetera. So it's not a benign thing to give patients antibiotics when it's not indicated. If it is indicated, different story. So if I have
we talked about that, how many dentists did not know the first line of drug for anaphylaxis is epinephrine?
Yeah.
Okay.
Yeah.
And then on top of that, patients that get C. diff, 25% will have a recurrent infection once they get it the first time. Yep. All right. And in fact, on this show, we talked about the fecal transplant, Ray Biota. All right. And that's something new that came out for that as well, too, as well as, vancomycin is the first drug, and then the other drug of fidaxomicin as well, too.
Yeah. So those are used for treatment. And then the other thing in the news is that the opioid rescue drug, naloxone or Narcan, has been approved by the FDA to be sold over the counter.
On the counter.
And it's going to be Walgreens, Rite Aid, Walmart, CVS, probably Costco too, for about $45 for a box of 2 doses. And that's about half of what it was before. I think it was about $100. And you had to have a prescription from a physician for a family member to go, or a patient to go buy naloxone, to have Narcan with them in a nasal spray.
And remember, that's a nasal spray. You do not have to prime it. All right. It is ready to go.
Spray.
All right. Single
one
spray.
shot. That's it. Yeah,
that's right.
Exactly. And then you have a second dose if necessary.
Airway.
Yeah. And pretty soon there'll be one of the drugs we talked about a couple months ago, Revive, is similar to naloxone. It's an opioid antagonist, but it's basically has a longer duration of action. Yes. And so that's probably going to become also over the counter in the near future.
Yeah, as long as these opioid overdoses continue to increase, has to.
Yeah, that's absolutely.
All right, so Jay, we got 10 drugs to go through.
We got 10 drugs. We're going to have to talk fast.
Medical emergency. Yeah. So we might just want to hit the highlights for everybody.
Okay. So our first drug is Izivare, otherwise known as Avicin Captad Pegol. It's an intravitreal solution, which means it is injected directly into the eye. Yes. And this is for treatment of geographic atrophy, which is something that occurs as a secondary event to age-related macular degeneration, to dry AMD. And you can see here what it does. It starts close to the fovea. And what happens with this disorder is that there's overactivity of complement system and in specific, particular C5. And what it does is it starts basically separating the fovea from the underlying tissues, and I'm sorry, the retina from the underlying tissues. And so what this does is it creates blind spots. It creates scotomas, which are basically kind of like flashy light kind of things that people with migraines know all about, and can lead to big changes in your visual acuity and eventually blindness. And it usually affects both eyes, not just one or the other. So if you happen to talk to someone who mentions that they they are known to have AMD, and they start saying, well, it's getting harder to read, I can't see as sharply, I'm seeing some dark spots or blind spots, it's harder to see when the light's dim, or even things don't look as vibrant as they used to be, they very well could be moving on to geographic atrophy. And the risk factors, biggest one is increasing age. So the older the patient gets, the more likely, and family history. Smoking really makes a big difference, even if the patient has quit smoking. No gender differences. And they also found that users of thyroid medication or antacids had an increase in the risk of geographic atrophy. And so those are the symptoms. And the other thing that was noticed is that people with higher education seem to be at lower risk of geographic atrophy. Patients with coronary heart disease and lens opacities, previous cataract surgery are also at increased risk. And one of the strongest risk factors was having bad vision to begin with. So if someone is 20/200 in their teens, they have a much higher risk of developing geographic atrophy. And they're not really sure exactly how this occurs. It basically starts as a typical AMD and then just advances. So what this drug Iverray does is it targets the C5 to decrease the activity of the complement system and slow the progression of the disease. And it's given directly into the vitreous of the eye. And you can imagine there are a few complications of that, including retinal detachment, going from dry AMD to wet AMD, and increased intraocular pressure. So now that brings us to our next drug, Zurzuvae.
What a name, Zurzuvae.
Zurzuvae, pardon me. And so this is for another entity that you may very well see in your practice. You have a patient who had a baby not too long ago, within the last couple months, and they start to exhibit stages of postpartum depression, which are characterized by depressed mood and kind of loss of interest in activities. And so what this drug does is it's specific for treating postpartum depression. In fact, they did some studies to see if it would treat garden variety depression, and it actually wasn't all that successful. So postpartum depression is a lot more common than you think. It occurs in about 6.5% to 20% of women, generally before 6 weeks after childbirth. And like I said, they may cry more often than usual. They may be angry, withdrawing. They may feel disconnected from the baby. They're afraid they're going to hurt the baby. They may be suicidal. It's a significant problem. And this drug is thought to work by modifying the GABA A receptors. And it's, altered neurotransmission of GABA has been implicated in the pathogenesis of depression. And this drug is similar to an older drug that's been around for a while called Zulresso, but the difference is this has better bioavailability when taken orally, so it can be taken orally rather than an injection.
Yeah. Zulresso was an intravenous injection only.
Yeah. And so with that, we will move on to our next drug. So we've got so many to go through, and that's Talvey. Or
MAB drugs that we discussed earlier in the very beginning.
Yep. Talquetamab TGVS. And remember, that's just a suffix that doesn't mean, it's just a random assignment of letters. And so this is a first-in-class drug.
That's right,
John?
Yeah, just like what we said, we're going to see more and more of these first-in-class drugs, and you're going to hear it first on PharmaDocs before you're going to hear any other pharmacology lecture.
Yeah. And, it works by basically engaging T cells to treat or to attack the multiple myeloma cells. And as you know, multiple myeloma is a type of intra-bony cancer where the plasma cells become malignant. And so not only do they not function normally, but they excrete a lot of proteins that can get trapped in the kidneys that can cause all kinds of problems. And, there are a number of strategies for treating it. But in patients that have had multiple lines of treatment, such as proteasome inhibitors, immunomodulatory agents, and anti-CD38 monoclonal antibodies, and those have all failed, then this is a drug that is indicated for patients who are not responsive or who have recurrent, relapsed, or refractory multiple myeloma. And this was given an accelerated approval because it showed definite clinical benefit. And so the symptoms you can see there on the right of the slide that you'll see with multiple myeloma are, can affect circulation to the brain, so confusion and drowsiness, recurrent infections, kidney problems is the big one, bone and back pain, and fatigue, general feeling of not being very well, unexplained weight loss, spinal cord compression, and nausea and loss of appetite. And one thing to keep in mind for patients who have multiple myeloma is, what would you say, John? Patients in general have multiple myeloma. That has a big impact on what we do in dentistry.
Well, their white cell count.
But they also, a lot of them are taking bisphosphonates, IV bisphosphonates, to slow the progression of the disease. And we all know how bad Iridia and Zometa are when it comes to developing medication-related osteonecrosis of the jaws. And now we're finding that denosumab, which is Prolia and Xgeva, also I've seen some cases of hemorrhage in those patients. And so, multiple myeloma patients, for a number of reasons, you should have a little red alert when these patients come into your office because of all the issues that you have to think of when you're deciding how to treat them and what setting to treat them. So this drug works by, it's a subcutaneous injection, either weekly or biweekly. And basically what it does is it stimulates both CD3 on the T cell receptors to activate the T cells, and then it causes them to release pro-inflammatory cytokines to attack the myeloma cells. All right, John, why don't you talk about
Akega. Let's talk a little bit about Akega.
Abiraterone acetate.
And niraparib.
Yeah, it sounds like a drug combination to me.
Absolutely. And so it's a CYP17 inhibitor, and it's the polymerase inhibitor combination, which is indicated with prednisone for the treatment of adult patients in a suspected deleterious BRCA mutated metastatic castration-resistant prostate cancer. Now that was a mouthful. Okay.
Yeah.
All right.
And, this is seen in about 15% of patients. Actually, it's of patients that have prostate cancer, and it basically foretells a worse outcome, a more aggressive disease. And in fact, 1 in 8 men will be diagnosed with prostate cancer during his lifetime, and it's more likely to develop as you get older. And in non-Hispanic Black men, they found an increase. And about 6 cases out of 10 are diagnosed in men 65 or older, and it's very rare under 40. And you can see in this chart, I don't know if you can see my pointer here, but under the age of 40, prostate cancer is very rare, and it kind of peaks in the 75 to 84-year-old range. And on the bottom graph, we can see that since 1992, the incidence of prostate cancer has gone down actually precipitously at first, and then kind of plateaued and going down again. And now it's hard to tell if it's going back up again. But you look at the death rate from prostate cancer has pretty much stayed the same across the board, even though the number of cases diagnosed have increased.
And Jay, the thing about it, this drug just happens to be a combination of 2 drugs that have already been around for quite some time. Zytiga and then Zejula. And then they combined the 2 together, and that they saw a significant stat here, 47% reduction.
Yeah, they work by reducing the production of cytochrome P450-17A1, which decreases the production of testosterone, which is, we know stimulates the growth of prostate hormones, prostate cancer rather. So it works by basically being cytotoxic to the cancer cells and inhibiting the enzymes that will cause break in payroll and DNA repair. And this was also, it was approved, as we said, with prednisone. So it's taken in a combination with 10 milligrams of prednisone every day. And you can imagine with a drug like this, there are all kinds of side effects, and common ones, just lab abnormalities, myelodysplastic syndrome. You can even develop acute myeloid leukemia, AML, myelosuppression, hypokalemia, hypoglycemia. And so this is a drug, again, that is not used except for a certain subset of prostate cancer that is much more aggressive. And so if you've got a patient with prostate cancer who is taking this drug, you got to be very careful about their white blood cell count, about their ability to fight infections, and their ability to respond to being able to heal from what you do. All right. The next one is a very interesting drug called Hapazo or melphalan. And John, why don't you tell us about this one?
Yeah, that's an alkylating drug that's used in the liver. It's a directed treatment for adult patients with uveal melanoma, that these patients have unresectable liver metastases.
Right. All right. So uveal melanoma, as you would guess from the name, is a really rare form of cancer that affects melanocytes in the eye. And it's very aggressive, and about half of all patients with uveal melanoma will develop metastatic disease, with the majority, 90% of them,
90%
being in the liver,
and
and occupying a large portion of liver and interfering significantly with liver function. And less commonly, it metastasizes to lung and bones. This is a liver-directed treatment for non-resectable hepatic metastases, or if you have extrahepatic disease that is not amenable to resection or radiation. And the way this works is pretty interesting. This Hapzato kit, what it does is it basically the blood, so they cannulate the iliac vein, and it looks like the blood return back into the internal carotid, and the blood is pumped through this bypass pump through basically through the liver. And what it does is it allows a very high concentration of this alkylating drug to infuse into the liver, and then it takes the outflow from the liver purifies it, filters it, and then pumps it back into the central circulation. So they do this for like 30 minutes at a time. And so they're isolating the hepatic venous blood flow, and they're basically saturating the liver with this chemical. And so it's a really novel idea that seems to be working, and it uses this proprietary hepatic delivery system about every 6 to 8 weeks. But as you can imagine, when you do something like this, there are a lot of peri-procedural complications that can occur, like hemorrhage, hepatocellular injury, and thrombotic events. So because it's so dangerous, it's in a restricted program called the HepazoKit REMS. And we've talked about REMS before. And so, but for this rare disorder with unresectable hepatic Mets, or same thing of the lungs to the bone, this is a new option for those patients. All right.
And here's another drug for multiple myeloma, Rexfio.
Yeah.
And so it's, again, for patients with relapse or refractory multiple myeloma. So already 2 drugs released this month.
Yeah.
All right.
Yeah. And they're both basically treat the same disease, but different aspects of it by different mechanisms. So this, whereas Talvey used the GPRC5D pathway, this is the BMCA, the B cell maturation antigen that is targeted by this antibody, and it basically does the same thing, where it targets targets the cancerous plasma cells, okay, and it basically it's directed to them directly, and so this is a used for refractory treatment when the patients had more than 4 lines of therapy that haven't worked. And this was approved under accelerated approval. And
it's also in REMS as well, too.
Yeah. And so they will basically, have to be having multiple more clinical trials to see if it really is as effective as it initially seemed.
And for y'all out there, most people that are put into a risk evaluation or a REMS strategy, they're followed for like the next 10 or 15 years.
Right. Yeah. So again, what this does is just like Talvey, it activates the T cells to attack the myeloma cells.
All right. So Jay, we're already 6 drugs in. We got 4 left to do. Amazing, huh?
We're up to
Sohonos.
Palovarotene capsules.
For FOP.
And this is for a very interesting disorder that you probably have never seen or even heard of. And I don't think in all my years of dental school, medical school, and residency, I ever saw a case of this. And what fibrodysplasia ossificans progressiva is, or FOP, is a basically disorder in which tissues that are not supposed to ossify become ossified. And you can see, it basically progresses through the patient's body. It's a rare genetic disorder of the connective tissue, which causes this heterotropic ossification in tendons, in ligaments, in joints, in skeletal muscles even. And it progresses throughout the patient's life. And generally, these patients have a life expectancy of no more than 56 years. So it's a very debilitating disease, but it's extremely rare. And so this drug, basically the way it works is it's a retinoid acid receptor gamma agonist that works by mediating the interactions between the receptors, growth factors, and proteins. And essentially what it does is it works within this retinoid signaling pathway to reduce new abnormal bone development. And this, again, is a drug that has many side effects. It's got a boxed warning. It's a oral once daily dose. It can cause premature epiphyseal closure, microcutaneous adverse reactions, metabolic bone disorders, psychiatric disorders, and night blindness. And it's especially, you got to use a lot of caution in pediatric patients as young as 8 years old that may suffer from this disorder. All right. Next is Elia.
HD.
Yeah, HD.
So another drug for
High
macular
definition
degeneration again too.
Yeah, of aflibercept injection, and this is basically a higher dose formulation of an approved vascular growth factor (VEGF) inhibitor that is again used for a disease we talked about a little bit earlier of macular degeneration. In this case, we're talking wet macular degeneration, which is where you get leakage of fluid into the retina because of neovascularization. And in addition, this is also indicated for treatment in diabetic macular edema and diabetic retinopathy. And so you can see, there's what a normal retina should look like. There's our foveus and talus right there, our area of sharpest vision. In diabetic retinopathy, you get these patchy areas where you have, because of long-standing diabetes, the blood vessels will actually become brittle and leak. And in AMD, what differentiates, again, dry AMD from wet AMD or neovascular AMD is that you get vascular neogenesis, and these blood vessels leak. They leak fluid into the retina and cause progressive blindness. And this, again, is given by intravitreal injection every 4 weeks, and then spread out after the first 3 months to just every 8 weeks. And again, this is just a higher dose formulation of a medication that's already been approved. So the benefit of this is it only has to be injected every 8 weeks instead of 4. And so this was given demonstrated unequivocally in trials a significant increase or improvement in vision gains compared to Elia, which was given every 4 months. All right, let's move on to the next one. Viopause. This is something for a disorder that's a complement C5 inhibitor. This drug is a complement C5 inhibitor for treatment of adults and pediatric patients with something called Chapel disease. So tell us about that, John.
Chapel, CD55 deficiency with hyperactivation of complement angiopathic thrombosis and protein losing enteropathy, or CD55 deficient protein losing enteropathy.
Wow.
All right.
That's a mouthful.
It is. I've been given a lot of mouthfuls tonight.
Yeah.
Okay. So
Chapel is a lot easier than saying the whole name. So it's basically the disease is driven by overactivation of the overactivation of the complement system.
Yeah,
and, so
it's both a life-threatening gastrointestinal and cardiovascular disease.
Yeah, because patients that have Chapel disease have all kinds of disorders because of a wacky complement system, and so they get leaky blood vessels, leaky gut, and all kinds of gastrointestinal and cardiovascular symptoms that are potentially life-threatening. And so these people are unable to regulate complement activity. And so what this drug Viopause is a IG4 antibody that binds with very high affinity to the wild type and variant human C5 by blocking the activity of complement factor C5, which is a protein involved in the complement activation system. And it's administered intravenously through an infusion, let's say on day 1, and then weekly after that. And of course, there are lots of side effects from this too, like bacterial infections, including gonococcal infections, systemic hypersensitivity reactions, and immune complex formations. And so, if you have a patient on this medication, you have to be very aware that they are more susceptible to any type of bacterial infection and hypersensitivity to medications or even materials that you may use in their treatment. All right, John.
Last drug, Jay. We've gone through 10 medications.
Give us the spiel on
Tyruko.
Yeah.
Natalizumab. All right, so there we go. Another MAB drug. So always remember the last 3 letters, MAB, and of course the letter in front of that source will also determine where it came from as well too.
Yeah, UMAB would be human source.
Human source, that's correct. And so this drug is used to treat multiple sclerosis, MS, or Crohn's disease also as well too. So
that's interesting because both of those disorders seem to be different disorders.
That's right. But now this is.
But how are they? Are they related?
Now, this is an integrin receptor antagonist biosimilar to the drug called Tysabri.
Yeah. Yeah. Well, the things that multiple sclerosis and Crohn's disease have in common.
They share some commonalities.
Yeah, they're both autoimmune disorders, and 70% of people diagnosed with MS have some type of bowel symptom, which may be due to IBD, which is Crohn's disease is a form of. And patients with MS may be 1.5 to 5 times more likely to be diagnosed with IBD compared to the general population. And they share similarities in their disease pathway and the inflammatory response. And the thought is that it may be related to the TNF alpha, or tumor necrosis factor alpha pathways. So that's interesting. The 2 diseases that don't sound like they're related at all may have some similarities.
So and this drug too, Jay, is the an FDA first approved Tysabri biosimilar as well too.
Yeah. So it's basically similar to a drug, natalizumab, natalizumab. There we go. Got it. And this is just, biosimilar, which means it's basically works identically, but there's a little bit of a molecular difference that allows them to call it a different drug.
And Jay, okay, so in all of these drugs, I guess probably 6 of the 10 we've presented tonight are all involved in a REMS program as well too.
Mm-hmm. Yeah.
So think about all of the information they're going to obtain over the next 15 years following all of these patients. And we haven't even scratched the surface on all of the new drugs that will happen then too.
Exactly. All right. So now let's move on to our medical emergency of the month, something that could happen at any time, any day in a dental office.
And we've been talking about it all night tonight, I think, as well too. So let's see. Crushing chest pain.
Sweating.
Nausea. Not relieved by nitroglycerin after multiple attempts. I wonder what's happening.
What's happening? Well, these are some of the signs and symptoms of a disorder that we call myocardial infarction. And you have to remember that myocardial infarction and a cardiac arrest are not the same thing.
And a sudden cardiac arrest are not the same thing.
Sudden cardiac arrest is basically an electrical problem where the heart just goes into ventricular fibrillation, whereas a heart attack or myocardial infarction or even ischemia is a circulation problem. It's a plumbing problem, generally due to atherosclerosis. And so the way you differentiate these patients clinically is, a sudden cardiac arrest victim is going to be unresponsive and not breathing.
Just like that.
Whereas a heart attack victim is going to be very uncomfortable, but they are responsive, they're breathing, and they don't need CPR or defibrillation yet.
And Jay, one way I like to talk about it in my lectures is like, okay, before that heart attack, they were having angina. They were having chest pain.
Yeah.
So the sequence could go angina, then into a myocardial infarction, then that can lead into cardiac arrest if this is not treated correctly. Okay.
Right.
So that's your pathway right there. Whereas sudden cardiac arrest is all out there by itself.
Yeah.
All right.
Yeah.
And the two treatments for that, defibrillation and great CPR.
Yeah. And as we mentioned earlier, they're finding that up to 50% of patients have some type of symptom beforehand, either like chest pain in men or nausea in women.
I mean,
all right,
isn't
so
that great? We're starting to scratch the surface on that now.
Yeah.
Because
all right, so let's take a closer look at our algorithm.
About 1,200 people die every day of a sudden cardiac arrest.
Yeah, it's and it's not getting any better.
No, it's
people
not.
Are getting people are eating worse, not exercising, and getting obese.
And
so at some point, we're going to have to put an end to that.
But you got to be shocked. You got to be shocked quickly.
Yeah, that is the key. Quick defibrillation.
So as we go through this algorithm right here, I mean, we've got to already realize they've gone from an anginal situation. Now they're into what we would call a myocardial infarction.
Right. The nitroglycerin is not working. That they either they carry themselves or you have in the office. They're diaphoretic. They're nauseated. And they just don't look good. So obviously what you're going to do is stop what you're doing and call 911 immediately. And as far as positioning the patient, you're not going to lay them supine. You're going to let them basically sit in the most comfortable position for them. And that may be completely upright or it may be slightly reclined. But, and so
we've already gone through nitroglycerin. So now your next drug is aspirin, either
and oxygen,
and oxygen as well too. Absolutely.
Yeah. So oxygen is used for most medical emergencies, except for, of course, hyperventilation. And so if you're suspecting a myocardial infarction, get the patient on oxygen. You've called 911. Give them aspirin, the children's aspirin that's chewable. It seems to be most people's favorite because just the regular aspirin tablet is extremely bitter. Have your AED ready and be prepared to start BLS if the patient becomes unresponsive. And as John said, goes from that MI to an acute stoppage of their heart, right?
Right. And, you know, Jay, we've always heard about Mona, M-O-N-A. Do you carry morphine in your office? I don't.
We do, actually.
Okay. I do not. So, but the other thing is a lot of general dentists will not have morphine in their office. Okay. Yeah. But I mean, like we do have, you know, fentanyl, but the other acronym will be NONA, and the N for nitrous oxide.
Yeah. That actually is effective.
That can make the patient, that's right, very effective. That can make the patient comfortable until EMS gets there. But notice the last thing we did on our little quick reference checklist, prepare a patient for transport. Please do not drive the patient. All right.
Yeah. Well, that's number one, call EMS.
Correct.
And try to stay calm.
That's right.
As we recommend for all emergencies, because if you are not calm, you probably will not have a successful outcome or as successful as it should have been.
I love what I heard one time, Jay. If you prepared for the medical emergency will cease to exist. All right. Because everybody knows their role.
Yeah.
And
you have to be.
A medical emergency is not a solo person issue. It's a team issue. All right.
Exactly. And you sent me, I think, an article about a death in an office where a patient became syncopal, right? And basically kind of passed out. And there was nobody watching the patient. Patient became syncopal with nobody in the room watching her. And when they went back 3 minutes later, she was dead. From lack of oxygen, and then that leads to VFib, and then full cardiac arrest, where you can't resuscitate them. So that's another thing to remember is once you've given any kind of medication to a patient, local anesthetic, topical, whatever it may be.
Never leave that patient.
Never leave the patient alone.
Or
Always
make
have
sure have
someone of your
with
staff
that
with
patient.
them.
That's right. That's one of those never ever do things I call a Ned moment. Never ever do. All right. But it happens. I mean, a medical emergency happens every day in a dental office. There's so many of us treating patients every day. Something's happening, and there's a lot of near misses out there too.
Yeah. I had another patient this week that after just giving him fentanyl and midazolam, a healthy young girl went completely apneic for at least 5 minutes.
Yeah.
So we had to support her ventilation during that.
That's right.
Yeah.
Airway.
Exactly.
And thank goodness, Jay, you're in there titrating your medications instead of like one drug after the other.
Yeah.
Because what if you would have given propofol or ketamine right there? How much deeper would that patient have gone?
Right. Yeah. But the key is recognizing that right away. I'm anal about listening to every breath through my precordial stethoscope.
Yes.
And the pulse oximeter, listening for that tone with my other ear. And as soon as I hear either absence of breathing or a decrease in the tone of that pulse oximeter indicating the O2 sat is dropping, you know, I've seen anesthesiologists just kind of ride it out, figuring the patient will spontaneously start breathing again at some point when the sat gets low enough. But
no, attack it early.
I never let that happen. Once it goes below
early.
96, we are in action.
Attack it early. Absolutely. Right. Fix the problem before it becomes
a big problem.
Control.
Exactly.
That's right.
Exactly. Keep it a minor problem that you know how to manage.
All right. So those of you out there that want to learn all about pharmacology, stay up to date. Jay and I have on dentallearning.net PharmaDent. And you got the categories there, Jay?
Yep, there they are.
There. 15 categories. You'll stay up to date. There's no need to go try to find an all-day lecture on pharmacology because we've got it covered right there.
Yep. Drugs, arrhythmia drugs, drugs for breathing disorders, depression, anxiety, all the drugs that your patients will put on their medical history when they come into their office.
And I got news for you, Jay. By the time you leave that pharmacology lecture that you were there all day, take a percentage guess how much you're going to remember or how much you should forget. All right. You're going to forget about 75% of that knowledge. But on our PharmaDent, you can go back as much as you want to for the entire year.
Yeah, you can review it, which is one of the great things about online learning. But we're going to have an in-person learning experience in Cincinnati, Ohio, on October 27th at the Vesper Institute that John and I are both honored to be teaching at. And this is going to be our Advanced Emergencies and Skills Station airway and medical emergency management. And so this kind of expands on what we've been talking about. We've been talking about medical emergencies, every month. And this gives you some hands-on skill, because if you've never put in an oral airway, you've never put in a nasal airway, or had to put in a esophageal airway or ventilate somebody, the time to learn how to do it and do it hands-on is not
in the emergency
heat of the moment. No, you want to have experience ahead of time. And, we've all taken CPR and ACLS, and we know how worthless some of those classes can be.
But
John
not this class.
When we did Megacode back when we were in residency, it was hardcore. When I've done my ACLS renewal the last few times through a private company, it was not quite what it was.
Well, it's not dental related at all. It's not applicable to our offices. And what we're doing here is a first in class program that after we have our lecture in the morning, then we're in skill stations all afternoon, airway obstruction, AED with good BLS. Because, Jay, that's one of the 10 deadly failures in dental offices.
Oh, yeah.
Is bad not do bad BLS, shocking, and it's mandated in all the states. Okay.
Yeah.
Then the vital signs monitoring, we're going to cover everything there, whether it be blood pressure, capnography, pulse ox, what happens to the oversedated patient, and then the anaphylaxis station. What all do you give, and can you give it in that dedicated time period? And guess what else you have to do in anaphylaxis? You got to maintain the airway.
Yep.
So how do you do all of that, Jay, by yourself? You don't.
Yeah, because your staff is not going to know.
No.
And if you've never had to do it before,
it's going to be total chaos.
Yeah, exactly. And we don't want that to happen. We want you guys,
we want
if
everybody
something happens,
ready,
to have a successful outcome.
Yeah, we don't want to read about that anymore. And look, how many of you out there have always dreamed about learning IV sedation? I know it has crossed many of your minds.
Yeah.
Well, Jay and I are, again, very proud to be part of the Vesper Institute IV sedation program. And it is going to be an awesome program.
Yeah.
All right. Jay and I love to teach, and we're going to love to be by your side during this incredible course.
Yeah, this is you're going to have about 45 hours of online learning before you come to the course.
Oh, more than that, Jay. We're going to be closer to 60 online.
60, okay.
Hours. Yeah.
And then another about 25 hours.
Correct.
In person.
Yes.
Taught by myself and you, and also Scott Sayre, who is actually the director of the Vesper Institute. Sorry, gone. Been a long day, and he actually has been incorporating IV sedation in his practice for the last 30 years. And every dentist who works in Dr. Sayre's office is also IV sedation trained. And they see patients that basically don't go to most dental offices. They're patients who are really afraid of dentistry, patients that need, special needs patients. And their practice is booming because they can treat all these different groups of patients. So we don't have the dates for next year yet, but if you go to VesperInstitute.com website, you'll be able to see our schedule. Well, actually, we do have the schedule for next year, don't we?
We do. When they
actually do.
Yeah, when they go to reserve their spot, it'll bring it up. I was talking to Dr. Sayre today, Jay. He was talking about he did 3 root canals today because the patient was anxious, and the endodontist that she had been referred to, or they had been referred to, did not sedate.
Yeah.
So, I mean, our IV sedation program is open to general dentists, periodontists, endodontists. And like what Jay said, it's going to be multiple stages. First, you're going to do your online, then you're coming to Cincinnati to do your didactics. And we might actually be having some modification of that with another meeting sometime next year. So and not only would it be in Cincinnati, it could be, say, in Las Vegas or maybe in Scottsdale or something like that. And then, like great. Jay said, that'll be 25
But not
hours.
in the middle of summer, please.
No. And then the last day of didactics is all day simulation with us and Rick Ritt. And we're very excited about that.
Then we're also going to teach you how to start IVs.
Yeah, we're going to have a venipuncture. And we're also going to be incorporating ACLS into this next year as well, too. And then after you finish part 1 and part 2, you go into part 3, your clinicals. And as Jay said, all of the general dentists at Vesper are IV sedation certified.
So
how
they are going to be.
Is that for you? I mean, this is an incredible program.
General dentists are going to be your one-on-one mentors for when you do your 20 or more IV sedation cases.
And hey, let me go ahead and make everybody feel good too. So after you get 20 or more while you're there, let's say you go back to your hometown where, let's say Jay's a general dentist, goes back, you know what? I'd like to get a few more. All you have to do is call Vesper and fly back out there. There'll be no charge for that.
In Cincinnati, Ohio.
And then you also become Vesper alumni. And Jay and I are going to have once a month meetings with everybody to discuss this. We want you to be confident and competent in this.
Exactly.
Check it out.
Yep. And another offering we have on dentallearning.net, as well as
I know that guy
is the responsible opioid prescribing for dentistry. It's a 3-hour course, so it covers the requirements for every state in the union, except for California, which has its own specific requirements. And so there's also, in addition to this course, there's also a California specific course that you can take. So our next get together is going to be October 13th. We're going to talk about some new drugs and some a new medical emergency. So we hope that you will be able to join us.
Thank you so very much being here with us. It means everything to us. We're all in the trenches with you every day because we are private practitioners as well. We just want everybody to do their very best.
And we'll see you next month. Thanks for joining us.
Absolutely. Thank
tonight.
you so much.
All right.